When a patient enters a clinic, they present a subjective, chaotic narrative of discomfort. The clinician's task is converting that story into an actionable intervention. The general scheme is an 8-step data filtering pipeline, from initial history to termination. It's a deductive algorithm that becomes a subconscious reflex. Clinicians focus heavily on the first 3 nodes, as 80% of diagnoses are eliminated in the history-taking phase. History-taking begins passively, occurring the moment the patient comes into view. It relies on immediate observation of their entry, their physical presentation, and their basic demographics. The physical examination provides clinical corroboration for a diagnosis the clinician has already formed by watching the patient and listening to their history. Recording age and sex is an act of epidemiological filtering. These variables isolate or exclude specific categories of disease, from congenital anomalies in infants to sex-linked conditions like hemophilia. Occupation serves as a separate data filter. A patient's daily environment exposes them to predictable mechanical stressors and specific hazards that correlate with localized tissue damage or neoplasms. The chimney sweep illustrates this correlation. Chronic exposure to abrasive soot and tar directly linked this profession to high rates of scroval carcinoma. Physical labor produces similar predictability. Miners working in confined spaces and athletes enduring repeated impact show consistent patterns of mechanical wear, such as tears to the medial semilunar cartilage. Geography and culture provide the next filter. Regional diets and localized parasitic distributions act as biological markers. A patient from a sheep-rearing district in Australia carries a statistically higher risk for hydatid disease. In Kashmir, a specific cultural practice produces a unique pathology. Traditionally, the kongri, an earthenware pot filled with burning charcoal, is carried against the abdomen for warmth. This chronic heat source generates a localized burn, leading to abdominal kongri cancer. Capturing demographics establishes the statistical baseline. It provides the mathematical probability required for subsequent diagnostic logic. The chronological imperative requires symptoms to be ordered by exact duration. Swelling followed by fever indicates a specific biological progression that changes if reversed. The clinician must identify baseline 0, the exact moment the patient was last in perfect health, isolating the true inciting incident. Leading questions should be avoided during interrogation. A patient seeking to be helpful will often answer yes to a specific suggestion, injecting false data into the model. Questions must be open-ended to hunt for the negative answer, serving as a high-yield diagnostic tool. Confirming the absence of a specific symptom is often the fastest way to strike a potential pathology from the differential list. For a patient with a sinus on the cheek, the clinician checks for watery discharge at meals. The documented absence of this discharge immediately eliminates the possibility of a parotid fistula. Patient omission is a constant variable in medicine. Patients frequently fail to mention resolved symptoms, assuming that anything that no longer hurts is irrelevant to the current problem. A historical, forgotten symptom, like old hunger pains, reveals the underlying cause of current abdominal rigidity to be a peptic perforation. The clinician extracts the unsaid timeline. They must identify the negative space and the forgotten history the patient does not know is relevant. The physical examination begins with observation. How the patient presents themselves in space provides immediate data. This phase is the general survey. The clinician scans mental state, physical build, gait, and decubitus, the patient's position in bed. Postural anomalies map directly to underlying deficits. A patient lying absolutely still is often guarding against the pain of peritonitis, while restless tossing is characteristic of colicky pain. This diagram illustrates the assessment of cyanosis. Visible bluish tinting requires a minimum of 5 grams per deciliter of reduced hemoglobin in the blood. On the left, central cyanosis indicates a failure of lung oxygenation, visible on the tongue. On the right, peripheral cyanosis reflects slowed systemic perfusion, diverting blood from extremities to protect vital organs. The general survey provides the systemic context required before the surgeon's hands touch the localized site of the complaint. Moving to the site of pain introduces the risk of tunnel vision. Clinicians often focus so intensely on the localized symptom that they miss the actual pathology. To prevent this, inspection requires total exposure of the affected area and immediate comparison to the corresponding normal side. A common error in the local exam is failing to palpate the regional draining lymph nodes. This step is essential for accurate diagnosis. The general exam is mandatory because a localized symptom is frequently a distal manifestation of a remote issue. Isolated knee pain is a classic example. The underlying pathology often lies in the hip joint, or in some cases, torsion of the testis. A systemic check also prevents surgical failure. Repairing an inguinal hernia without addressing a chronic cough or prostate enlargement ensures the hernia will recur due to persistent internal pressure. The physical exam is a test of clinical discipline. The clinician rigorously evaluates the entire system to validate the local complaint. Special investigations provide narrow confirmation of the provisional diagnosis generated by the history and physical exam. A complete clinical diagnosis identifies the ailing organ, specifies the pathological process at work, and maps its extent in all directions. The flowchart now enters the execution phase. Medical and surgical treatment is followed by rigorous progress tracking and follow-up, creating a continuous data loop. This loop concludes only at termination, the final record of whether the patient was cured, relieved, or deceased. This 8-step scheme is only effective if the clinician possesses the foundational medical knowledge to interpret the data. Recognizing a symptom requires the prior knowledge that the symptom exists. In surgery, one axiom remains absolute. Eyes do not see what the mind does not know. The algorithm works only if the mind is prepared.